Thank the organizers of this impressively arranged conference, Kuwait Ophthalmology Conference. And I'd like to thank Bayer for the opportunity to present this never-ending journey, as we could say. So I'm Dr. Mohammed Al-Ajmi. I'm a senior specialist vitreoretinal surgeon in both Adan Hospital and Al-Bahar Eye Hospital. And we'll go briefly through some information regarding diabetic macular edema. So to start with, the global burden of diabetes will continue to rise, as you could see with the very, let's say, worrying numbers, especially in Africa and Middle East and North Africa, where the burden of disease could probably overwhelm the healthcare systems in such countries if we don't do something about it. Now, so what burden is on the patients? DME, diabetic macular edema, can have life-changing consequences. Difficulties performing near vision tasks where you need the higher resolution of vision, reading, perceiving colors, driving, losing the license. The driving license, mortality risk compared to normal vision is increased, and psychological impact due to increased ability to perform normal life activities could lead to depression, for example. So patients with diabetic macular edema are typically of working age, and so their expectations of quality of life is normal for their age. So losing that has high impact on their livelihood, on their psychology as well. So as much as losing vision can be impactful, regaining vision is also very impactful for such patients. So gaining one line can help a patient read newspaper or drive at night. 2 lines can help them in near vision tasks, cooking, tools, working, or allowing patients to focus on activities for longer, even for office work. 3 lines can help with color perception, and this is helpful for some types of occupations, or even for normal day-to-day function. And maintaining 20/40 vision or better, which is essential for retaining the driver's license. So to decide the treatment choice for diabetic macular edema, there are several sources. RCTs with a high level of evidence, recommendations, real-world evidence, and somehow the mechanism of action of the variety of anti-VEGFs available. So let's talk first about randomized control trials. So VIVID and VISTA, the study where we get the approval for diabetic macular edema treatment for aflibercept, Eylea, and here it's done compared with laser, with a regimen of 4 weekly versus the 8 weekly. So, where intensive treatment was maintained in year 1, fewer injections in year 2 and 3 as we extend the treatment to the 8 weekly. So again, here is when we are comparing the 4 weekly regimen and the 8 weekly regimen, and you could see that after the 2nd year, the number of injections in the 8 weekly is reduced, while the visual acuity change is almost the same as the 4 weekly regimen. Now, there was a few studies that were done. We'll go through them quickly. So the AQUA was a multi-center open label, phase 4 post-marketing study. And it's also studying the quality of life outcomes in patients. And this is due to the license dosage. So 5 monthly loading doses and followed by 8 weekly. So the main change of vision from baseline was almost 10 letters. And you could see the change, how it helps in the near activity work, the distance activity score, and total score in patients who were treated in the better seeing and in the worse seeing eye. Now, another study was the Violet study, and it's also regarding the long-term and reduced treatment burden when we go with the extended treatment regimens. So patients who had 8 weekly fixed regimen compared to 8 weekly who were treated and extended to 10 weekly, 12 weekly, depending on their response to treatment, and those who received the aflibercept PRN. And you could see how comparable the changes in the visual acuity is among all the arms of the study, and the percentage of patients who gained more than 10 letters at week 52 is higher with the treat and extend arm and with the PRN arm as well. So it also shows us that we can actually extend the treatment and lower the burden of treatment on patients while maintaining good vision outcomes. So again, another study which evaluated the outcome of a 2-year proactive treat and extend treatment, and again, a multi-center prospective single-arm study, and went for 2 years. And again, 4 weekly for 5 months, and then individualized treat and extend, which is probably the way we are treating our patients. We don't have a fixed regimen for patients post the 5th injection. We mostly individualize according to the patient situation, diabetes control, the facilities, the healthcare, the insurance availability. So again, we could have a look at the outcome, the patients at baseline and then patients at year 1 and year 2, and the number of injections which has reduced remarkably from year 1 to year 2 by adopting a treat and extend. And 57% of patients were on 12 weekly or more by the end of year 2, which is probably what you want. You want to inject your patients less while you gain more. Again, here, Hirano et al. Assessed the proactive individualized treat and extend treatment over 2 years. Again, multi-center, open-label, single-arm, and started by the classic regimen of approved 5 months, followed by individualized treat and extend. And the results are also similar. There's still more gain, but here almost 66%, 2/3 exactly of patients were on a 16 weekly for monthly almost treatment by the end of second year. So the licensed posology for aflibercept in the EU is 5 doses followed by extending to 2 weekly. And we could also go, according to these real-world studies, that we could go with further extension depending on our patients' control. So these are the studies. Now the recommendations, most of the guidelines have recommended the use of aflibercept as a first line when it comes to vision worse than 20/40. We could go through those guidelines as well. The DRCR Protocol T, which studies the faster rapid improvement using aflibercept at year 1, even though at year 2 almost the results were comparable between the compared anti-VEGF agents. And again, aflibercept was noted to have a rapid, more rapid recovery during year 1 with patients who had a worse baseline. So again, we'll go for the meta-analysis of RCTs and 24 studies, 6,000 patients, and especially with patients who had vision between 2200 to as good as 20/40. And in year 1, again, efficacy outcomes favored aflibercept, and as it was shown in the Protocol T of the DRCR study. So let's have a quick review of the mechanism of action. Aflibercept is a VEGF trap, and it has an effect on the platelet growth factor as well, with the VEGF dimers, and that's how we assume it looks from the electronic microscope. Again, when we base the molecular properties with VEGF suppression time, ranibizumab, according to the studies, up to 36 days, brolucizumab up to 52 days estimated, and aflibercept probably up to 71 days. And the binding targets of the multiple anti-VEGF available in the market to subtypes A and B in aflibercept. Ranibizumab is more higher affinity for subtype A, as well as bevacizumab, and with faricimab, it's also has an affinity for angiopoietin 2. Now, when we go to the real-world evidence. So patients with a baseline of less than 68 letters had more greater visual acuity gains with aflibercept, as we've seen over year 1, and again at year 2, the arms are kind of become almost neck to neck. And so the effectiveness is that the early intensive treatment, especially in patients with worse visual acuity, could give them a good push and good improvement, which would affect their quality of life. And we could say it's probably, if financially viable in a healthcare system, to be a treatment of choice for patients with worse visual acuity. There's the more recent DRCR protocol AC, which discussed the comparing of use of bevacizumab compared to aflibercept, and starting with the dose of bevacizumab and then converting to aflibercept. It showed that patients who did not improve much on bevacizumab could still regain almost the same level of visual acuity by the end of improvement, generally by the end of year 1, if they were shifted to aflibercept. So we could design our own protocols depending on our real-world experience, and such guidelines and protocols would help us gain the best cost-benefit according to each system. My approach to patients with DME is usually tailored for each patient's situation. I have a holistic look at the patient, in a way, not holistic medicine, God forbid, but to check how the patient is having his diabetes controlled, how the patient is willing to attend multiple injection appointments, other comorbidities, dialysis patients, patients on wheelchair, patients with some sort of phobia of injections, claustrophobia. So you need to look at your patients as a whole and to control the whole. I mean, DME is just one of the diabetes complications. So you need to treat the patient as well. You need to remember that you're a doctor, not just an ophthalmologist, when you treat patients with diabetes. And with that, you can design or tailor-made your treatment for every patient according to their individual needs and individual complications. You might be the first to refer the patient to a nephrologist because patient was not able to see, so he thought, I need an eye doctor. He never thought of needing a nephrologist. So that's my message to you. Now I would take any questions or any discussion. Thank you so much for listening. If there's any, we're done? All right. Thank you so much for attending.